How's everybody doing? Should I get rid of that thing in the corner, Jeff? Since because I'm going to be walking over here probably. That's good. All right. Whew. Sorry, I'm a little late. So we have a good crowd here tonight. And the mic's working okay? Any EMRs? One EMR. EMTs? Sweet. Advanced EMTs. Medics. So good mix. In addition to Jeff streaming this tonight, I have a shorter version of this on video. I'll share it on YouTube for people to go that goes over the protocol as well. I think there's some really exciting changes that are happening in stroke care. It's really going to impact what we're doing with EMS, and this is going to be a lecture on stroke. We're going to review types of stroke, kind of the bread and butter stroke stuff, but I really want to get to the nitty gritty of something called the FAST ED scale, which is something that we're going to be doing. We can start using it tomorrow if you want. Vermont is officially rolling this out with the protocol cycle that all of Northern New England is actually going to be following the same protocol. Their rollout, I think, March. You thinking, Mark? Yeah, I think they usually said January, which in state times means March, or that's kind of like New Hampshire, sort of on the same track. So I did want to acknowledge a couple of people. Oops, am I not sharing here? There we go. Tom Tremarco, he's my counterpart up at Dartmouth, and Tim Lukovic is a stroke neurologist at Dartmouth. A lot of these slides are taken right from their stuff. I worked collaboratively with a lot of their stuff, but they did a ton of background on this stuff. So some of the stuff is just happily stolen right out of their talks. Going to go over a little background, go over types of stroke. I think it's important just to kind of review that. History and exams, super important, especially I'll talk about that time last Noel. We'll talk about our stroke screen, which all of you are pretty familiar with, and then the FAST ED scale, which is the big thing that's new. And then sort of our pre-hospital pearls and a little ED and hospital management as well. So Brattleboro and Cheshire's already been rolled out. Brattleboro and Grace Cottage are on board with the new protocol, although I will tell you, you might call in a FAST ED score to them and say FAST ED of 5 stroke alert, and they're going to say, what the hell are you talking about? It's going to take a little while. It's going to take people getting familiar with it. They have to do all their training as well, but this has been kind of sent to them as well, and they should be aware. So we talk about systems of care, right? I think EMS does a great job. We're all pretty familiar with trauma. We have STEMI care. We have our great STEMI protocol where I do my EKG. It's acute MI suspected. Somebody's having a STEMI. I notify a STEMI alert, get the helicopter going, get everything moving. We even have sepsis. That not necessarily that we have everybody, a whole team waiting, but the nurses are alerted and they're drawing blood cultures and getting a lactate and kind of moving those patients through the system. We've never really harped. I think we do a decent job here at stroke, but wearing my Cheshire hat, I think we've never done a great job of stroke. And the brain is important, right? I would argue it's probably the most important organ. It's a selfish organ. You need a lot of oxygen, a lot of glucose. About a quarter of the blood supply, cardiac output, goes just to the brain. So I think taking care of the brain is pretty cool. And even for cardiac arrest, I love cardiac arrest. Resuscitation is sort of my passion. And I would say 50% of what we're doing in cardiac arrest is for the brain as well. We talk about brain heart, but it's really that cardiocerebral resuscitation. We want to perfuse the brain, because if I get the heart back, I still have a person who's brain dead. It's not going to really matter. You guys are some of you familiar with the D's of stroke care, right? We have early detection, early dispatch, EMS notification, rapid EMS identification, transport, go to a stroke center. Vermont, I don't believe, has any official stroke centers. Either does New Hampshire. They just don't have a stroke designation. But what we do know is hospitals that have capacity to give TPA, and then which hospitals, not many of them, can do this mechanical thrombectomy, which we'll talk about for these big strokes, these large vessel occlusion strokes. We'll talk about data. We now want rapid triage, evaluation, management in the ER, stroke expertise. So we don't really have a robust neurology coverage at both Cheshire. Grace Cottage doesn't have a neurologist. We don't have robust neurology coverage here, but we have teleneurology. They'll bring a computer with the neurologist to the bedside, and that's our workaround that works pretty well. Fibrolytics and these intra-arterial strategies, that's the mechanical thrombectomy I'm going to talk about, and then admission to a stroke unit or critical care unit. Big problem, 700,000 strokes in the US annually. about 1 every 45 seconds, one death due to stroke every 3.1 minutes, 4.7 million survivors, but out of those, about a million have functional limitations and can't work. Third leading cause of death in the US, leading cause of adult disability, $50 billion a year, and like a lot of our stuff in the US, preventable and potentially treatable. I just came from out to dinner with my family and had a like massive Italian dish with tons of cheese and fat and all sorts of stuff, and I'm sure that's not the right thing to do for preventing stroke, but we all kind of do it as Americans, right? So when we talk about stroke, there's two things. We're talking about a vessel that's blocked. So that's a blockage. I think that's what most of us intuitively think of a stroke. We think of a stroke patient who has an ischemic stroke. There's a blocked vessel from either a thrombus coming from somewhere else or a plaque, or we're talking about a ruptured blood vessel like a hemorrhagic stroke. So like I said, 1/4 of the cardiac output goes to the brain, lots of oxygen, glucose. And just to review the anatomy super quick, the big pair, we have these vertebral arteries that come up here and your carotid arteries, and this is your circular Willis here. And when we talk about these large vessel occlusion strokes and we're assessing of who do I want to notify them of this fast EV scale, because the time is going to change our stroke criteria, which I'll talk about in a few slides. It's these big vessels. It's like these middle cerebral arteries here, a big artery that's blocked. Those are where that we think that low-hanging fruit to help survivors, help patients well out beyond the 6 hours, which is what we've been using. So I'll talk about different strokes. Anybody know? There's old people in here. Mike, Chief, you know who the different strokes. Goddard. Come on, what you talking about, Willis? Who's a fan, right? Who doesn't know? Anybody not know who these people are? You all know come on. Like, every time I give this, people like, who are those people? So anyway. All right, so pathogenesis, we have hemorrhagic or ischemic. We deal with ischemic more often, 83%. Hemorrhagic is 17%. Intracerebral hemorrhage is about 59% of those, and subarachnoid is 41%. When I talk about subarachnoid, I'm not talking about I fell down the steps, hit my head of a subarachnoid hemorrhage. We're talking about these spontaneous ruptured aneurysms. And then out of the ischemic stroke, the atherosclerotic cardiac cerebrovascular disease, 20%. Lacuna would be like high blood pressure, lead these small strokes. And embolism would be like coming from, like I have atrial fibrillation that's been untreated. I'm not on warfarin or Xarelto or one of those medications, and I get a thrombus that goes and causes stroke. And then cryptogenic, 30%, we don't know what caused the stroke. We just know they had it. So hemorrhagic, we talked about intracranial hemorrhage, which is like here, versus subarachnoid. On a CAT scan, blood is generally going to be white. And this is 70% of all strokes. Intracranial hemorrhage is much more common than subarachnoid, and it's usually associated with uncontrolled blood pressure. These are pretty devastating. You know, about half of people are dead within a month, half of those in the first 2 days, and only 10% are living independently within 1 month. The risk factors: hypertension, older patients, people on coagulation disorders are more common. We see these awful situations. People are on warfarin having just a catastrophic intracranial hemorrhage. Alcohol abuse, 2 reasons there. One, they fall more often. Also, brain matter tends to shrink a little bit, and they can get different types of bleeds with that. And drug use, the stimulants, people who are using a lot of crack and meth and stuff like that. But the good news is we don't see any of that in Brattleboro, so we're covered. And then, have you guys been seeing more meth? Anecdotally, so we're starting to see over at Cheshire, and we've kind of had word that it's kind of coming into the area, which is great. So, and then the other worry that I have treating these patients, an ischemic stroke that can transform to a hemorrhagic stroke. So if I have a big stroke due to a blood clot, I get this edema around it, and if I give thrombolytics and I don't give thrombolytics early, or I get it late, a complication can be that I actually convert to a hemorrhagic stroke, and that's what makes us nervous as I think ER providers of giving thrombolytics to patients. Subarachnoid is when you have bleeding outside the brain tissue. So between, let's say, the outside of the brain, that subarachnoid, that covering of the brain. Usually it's an aneurysm that causes it. 50% of these are fatal, 1 to 15% die before reaching the hospital, and it's 1 to 7% total of all strokes, but it's badness. And a lot of times young people. So these last sudden, usually sudden onset is sort of the key, usually minutes to hours. I don't know if I have any volume on this or not, but. And it's that thunderclap headache. Ooh, so wasn't as loud as I wanted it to be. But so the classic, we talk about that, boom, they got a significant headache. Nausea and vomiting is really common with these, both intracranial and subarachnoid. So you ever had that stroke patient is a stroke alert, but they're just puking everywhere? That tells me that what a headache tells me more worrisome for a bleed as opposed to a ischemic stroke. Ultramental status, decreased loss of consciousness, and they're hypertensive, and they have signs and symptoms of increased intracranial pressure. What are some signs and symptoms of increased ICP? Anybody want to throw some out there? Not all at once. Bueller, anybody? Pulse pressure. What's the blood pressure going to be? High, right? How about the respiratory? How are they going to be breathing? Fast, maybe fast. Irregular, though. You ever hear Cheyne-Stokes breathing, like the periods of apnea and these weird kind of like, breathing patterns? What's the heart rate sometimes going to be? Low, yeah, because they actually get so much pressure, they affect the baroreceptors and they'll drop their pulse. What might they be doing with their arms? What might you see? Posturing. So there's like decorticate and decerabit. I think decorticate is supposed to be maybe a little better of a sign. Decerabit, they're both kind of bad. Decorticate, sorry. Decorticate, decerabit. And then pupils. Yeah, so part of me wishes they never taught in EMT school to look in people's pupils sometimes, because we so often get, I hit my head, I'm totally fine, I hit my head, and one pupil's a little bigger than the other, and their pupils are unequal. Unequal pupils is when there's a sign of herniation, so patients are going to be signs of increased ICP and unconscious. So those are the ones I worry about. I look at the pupils, but in general, when you hit your head, you shouldn't have like a blown or dilated pupil. If you're up and talking, it's not a big deal. So is that a ghost? All right, so let's talk about ischemic stroke. So this is usually, it's a blockage of an artery, right? It can originate from the heart or the arteries, 80–85% of all strokes. I think this is what we intuitively think of when we think of our stroke alert patients. The bleeds we see the bleeds, but they're just less common. We deal with this a lot more. Signs of symptom, numbness or weakness, especially on one side of the body. They may have some ultramental status, trouble speaking or difficulty understanding speech, difficulty seeing out of one or both eyes. They could be dizzy, trouble walking, loss of balance. They may complain of a headache. And location matters, right? Depends where the stroke is. So if I have a stroke and I hit Broca's area here, I'm going to have the patient who's dysphagic or aphagic. They can't get the speech out. They can't they're frustrated. They want to tell you, but they can't tell you. And that's going to be on the left side of the brain, and they'll have right-sided symptoms. If I hit Wernicke's area back here, they're not going to understand what I'm saying. They're going to look at you, you're going to be talking. They're going to be like, what are you saying? I don't understand. Visual problems back here. So really in these, this motor cortex here, this prefrontal, precentral gyrus, the postcentral gyrus here, that's going to be motor and sensory. And there's that homunculus. So depending on when you get that, it's going to be an arm or a leg or a part of the face. So real important to remember that if you have a stroke on the right side of your brain, your left side's affected. Left side of the brain, right side's affected because the fibers cross over. What helps also this gaze preference, and this is part of that FAST-ED scale we'll talk about. I think of the gaze preference as looking towards the stroke. So I have somebody who can't speak, and they're totally paralyzed on their right side, and they're going to be looking to the left. Their gaze preference is going to be left. They're saying the stroke's over here. It's on my left side. So that's kind of the way I think about it. But make sense? Okay. Am I going too fast? Speed okay? Okay. TIAs, you'll hear about these mini strokes or transient ischemic attacks last for as little as a minute to 24 hours. Although 24 hours, it's pretty big that they come up with that range. Average though is about an hour. These people are increased risk for full stroke, and that's why generally when people have these TIAs, they'll get admitted to the hospital. They'll get echocardiogram, make sure they don't have atrial fibrillation or a clot that could cause a stroke. They'll get an ultrasound of their carotid arteries to make sure there's no plaques that could have caused part of the problem. They get kind of this stroke workup to make sure that they don't have a cause because they're at risk for other strokes. Generally, we put on aspirin or they put on some other therapy like Plavix as well. And this is profound to me. Every minute you have an acute ischemic stroke, so every 60 seconds, you lose almost 2 million neurons, 14 billion synapses, and 7.5 miles of myelinated fibers of those axons. So that's incredible. So, hey, how are you? Anybody break the law? He's after you, man. All right, so when we do our history of present illness, when we talk to these patients, out of all the things that EMS does, I think the most important is this, what we call time of onset or time last known well. It's critical because that's what downstream the ER and neurology is going to make a lot of their treatment decisions on. So super, super important. So if, grandma went to bed at 10 o'clock at night and she wakes up at 7 with stroke symptoms and you talk to them, her time last known well is 10 o'clock at night. So super important. And we also know that that changes over, stories change all the time, right? I mean, who's had that experience where you talk to a patient, interview them, like, first response, you're interviewing them, and then the medic comes there or the ambulance shows up and they start talking to them and they get a totally different history. Patient does something totally different. It happens all the time. Happens between the EMS and the ED as well. You want to know what they were doing in the onset. So if somebody's exercising and they develop a thunderclap headache and they get stroke-like symptoms, I'm thinking more activity, intracranial hemorrhage, like a ruptured bleed or something like that. It's important to know. Is there associated headache and vomiting? That tells me more likely hemorrhage often. Was there a seizure? Do you guys know why seizures matter? Anybody hear of anything called Todd's paralysis? Not named after you, Todd, but although I've seen you with Todd's paralysis before. Kind of look like you're on your way there now. So anybody know what Todd's paralysis is? So Todd's paralysis, you can actually have a seizure and then you have residual symptoms of hemiparesis and it looks like you've had a stroke. And that's why if somebody has a seizure associated with stroke, we don't give thrombolytic because it might be Todd's paralysis. And that'll resolve on its own. Have they had a similar episode in the past? It's a question I ask every single patient, just about every patient I see, every complaint. Have you ever had anything like this before or kind of like this before? That's kind of my verbiage that I use because it's helpful. It makes me sound smart when they're like, oh yeah, the last time it was, benign paroxysmal peripheral vertigo. And I'm like, awesome, I know how to treat you, as opposed to like going down the rabbit hole. History of trauma associated with it, and are they on blood thinners? They're on anticoagulation is also super important. So again, that true time of onset is the most important piece you can get on scene. We only treat them from the last seen normal, and we know that the story changes. This is one of the few situations that it's real important to consider transporting a family member. Just bring them along, try to get them to go to the hospital along with you because we're going to want to know in real time and ask those questions. Other useful history points, again, if they're exercising, they're increased, extremes of onset, if they're using stimulants or doing something, a lot of times you hear of subarachnoid hemorrhage, people having like intercourse, have a subarachnoid hemorrhage or running or something like that. Is there associated headache? Again, the Todd's paralysis down there. And then what's their history before and a history of trauma associated with? Have they had a subdural, subarachnoid, or an epidural hematoma? So I think it's a really challenging diagnosis. There are lots of stroke mimics. So there are things that we call stroke alerts as both EMS and ED providers and end up not being a stroke and there was a stroke mimic. There are also chameleons. So there are people who have a stroke, but it's hiding. They can't really see their stroke. Dizziness is a big one. Vision changes, kind of the subtle stuff. That could be a stroke. Those posterior circulation strokes are really challenging. And those are the patients, like I had an interesting case about a couple of months ago of a guy who was basically time last known well was only a couple hours, was found down, and he had Cheyne-Stokes breathing, yawning, and super high blood pressure, and he had a GCS of 3. He was out to lunch. He then had a pupil that dilated during transport. We RSI'd him, brought him in down to Chester, and I'm like, this guy has a catastrophic intracranial hemorrhage. It just is. CAT scan, totally normal. So he had a posterior circulation stroke, and it actually caused enough ischemia in his brainstem that it did all the things you would see if you're hemorrhaging in the brain. So it could be challenging. And time is brain. So what are some stroke mimics out there? Take a guess on the things that we see that we may call stroke or think it's a stroke and it ends up not being. What are some alternative diagnoses? Some differentials. Anybody? Tumor, good. Emily? Hypoglycemia, that's where we check blood sugar. Somebody has something over here. Bell's palsy, good. Anything else? Drugs, you say drugs? Drugs, yep. Other big ones, there's one really big one that's a common one that we often, EMS says stroke alert, and then we end up doing another alert, but it's not a stroke. Sepsis is another big one because people get a little altered and goofy, right? And they're, so that altered mental status is challenging. So sort of the list I came with: hypoglycemia, seizures, benign paroxysmal peripheral vertigo. They have They're dizzy, they have vertigo, but it's an ear problem. It's not a stroke. Intracranial hemorrhage, migraine headache. People can get stroke symptoms of migraine. I can't speak. I'm paralyzed on one side, numb on one side of their face. That migraines can do that. Brain abscess, tumor, and sepsis. Sepsis is the big one. All right. So time is brain, right? And this is what we're dealing with. How do we, what's our stroke alert criteria? So what is the time last known well? What's the criteria we use right now? Todd. Do we use 6, right? Yeah, 6 hours. So we used to be 3 to 4.5, depending on where you look. Our protocol was 3 hours, and that's for thrombolytics. Then we realized that there are certain patients that can go for what they call mechanical thrombectomy. They go to interventional radiology. This to be done like at a center like Dartmouth, where they go in there, remove the clot. The best data we have is up to 6 hours we can help those people. So that's where the 6-hour time window came. Recently, though, this has changed. We know that some types of strokes, now our stroke alert criteria is out to 24 hours. So that's crazy. And this is how I felt, like, what do we do with this? Because initially, if you look at the stroke protocol that Vermont put out, they were talking about, if you have a positive Cincinnati stroke scale and time last known was less than 24 hours, you're a stroke alert. As a hospital, that can be a lot, because you can have somebody, I have a little bit of a facial droop and nothing else, or a little weakness in my hand, or a little numbness on one side, and my stroke screen is positive, my Cincinnati stroke scale, and I'm a stroke alert, and I was 8 hours ago, and I'm going to look at you and be like, yeah, whatever. But it doesn't matter. We can't help you. You don't have this large vessel occlusion. You don't have something we can help. So the key is how do we select the right group of patients so we're not overwhelming the system and holding CAT scanners and stuff like that, and having people drive lights and sirens to the hospital with their stroke alert when they could be a totally stable patient who I'm not going to do anything for, that's out of that 3-hour window. Make sense? So this is sort of the breakthrough treatment, right? This mechanical thrombectomy. The 2 trials were the 2017, they were the Dawn and Diffuse trials. They took TPA-eligible patients, time last known well less than 3 to 4.5 hours, mechanical thrombectomy for large vessel occlusion at 6 hours. That's where we were. And a couple years ago now, the Dawn and Diffuse trials were rolled out in 2018, and they found mechanical thrombectomy helpful for subsets of stroke patients with large vessel occlusions up to 24 hours. So can you guys hear us okay? It's a couple of videos I think are helpful. This is mechanical thrombectomy.
There's typically a blockage of one of the major blood vessels.
I can turn this up.
That blockage is often caused by a blood clot that forms somewhere else, like in the heart or in the carotid artery in the neck, and then breaks off and travels up and plugs up one of the main arteries going to the brain. So that part of the brain is at risk of dying because of the lack of oxygen and nutrients from the blockage from the blood flow. In situations like this, we can intervene going from the femoral artery in the leg, the catheter, as you can see here, place it in the carotid artery in the neck, through that catheter, we pick up a small catheter, a microcatheter, and catheterize the arteries inside the brain, the carotid artery, and the middle cerebral artery. You can see the clot within the middle cerebral artery, which supplies blood to that half of the brain. So we bring up our microcatheter all the way up into the middle cerebral artery in the brain and cross the blockage. Once we're across the blockage, we bring up a mechanical thrombectomy device, which is kind of a stent on a stick kind of configuration. And it's a stent-like device that we unsheath within the clot in the blockage. You can see the stent is opening up and actually restoring blood flow immediately. We then give it about 5 minutes, allowing the radial force of the stent to open up outward and allowing the clot to extrude from the lumen or inside of the stent. After the 5 minutes is over, we inflate a balloon in the carotid artery in the neck, which arrests flow, and then we pull back the stent retriever device with the clot entangled inside it into that balloon catheter. The purpose of inflating the balloon in the carotid artery in the neck is to reverse flow drain arteries and into the catheter out of the patient's body. In this way, any particles that break off from the body, then the stent retriever will get sucked out of the patient's body. They don't go out distally and cause more.
Crazy, right? That they can do that. So this is still a bit of a moving target. I think we'll see some changes, but this is the best available evidence we have at this point. I think it's pretty remarkable. Some of the stories you hear, we actually, some of the interventionalists will send us pictures of the clots they sucked out and patient outcomes and stuff. So I think it's pretty exciting therapy. It's just amazing that somebody was able to figure this out. It's like science fiction. All right, let's talk about stroke assessment. So we know the physical exam can be challenging, that there's a lot of the providers are poorly trained in neurological exam. A lot of assessment scales can be cumbersome. And FAST-ED is I think, the easiest we have. It's not super easy, but there's an app for that, which I'll talk about. And we know there's a heterogeneity of stroke presentations. We have those stroke mimics and, you know, or I should say stroke chameleons that are stroke that can be hard to kind of sort out sometimes. For assessments, ABCs, always, right? Every patient, unless you're cardiac arrest, we're doing CABs, but we're generally doing your general assessment. I love to just look at these people, and as we do this a while, get better. Are they sick? Are they not sick? What am I dealing with? Vitals, get your blood sugar, because one of your stroke mimics is hypoglycemia, and do your general, what I call your heart, lungs, belly exam. So less than 3 versus 24 hours. So you want to make it easier, right? You want to do a brief neuro exam, and that's your Cincinnati stroke scale that we normally do. And then if that Cincinnati stroke scale is positive, we move on to this large vessel occlusion scale, or this FAST-ED scale. The good news is the first few parts of Cincinnati are basically part of the FAST-ED. So you're starting your FAST-ED. So this is our new stroke alert criteria. Time lasting no well, less than 3 hours at a positive Cincinnati stroke scale, stroke alert. Time lasting no well greater than 3 and less than 24 hours with this positive Cincinnati stroke scale, and the FAST-ED is greater than or equal to 4, stroke alert. If they're greater than 3 hours and less than 24, and I do a FAST-ED scale and it's 2, it's not a stroke alert. Make sense? And we'll show some examples of this. All right. So the Cincinnati prehospital stroke scale, I think most people are using this. It's pretty predictive. If they have one or more of these 3 signs, they have like I think a 70 or 75% chance of this being a stroke. Facial droop, you want to have the patient smile, show their teeth. Arm drift, close their eyes, 10 seconds, hold it up like this, and you're kind of looking for if there's any arm drift, or they can not raise it at all. And then speech, you say you can't teach a dog, old dog, new tricks. I think in Boston, they say something like the sky is blue over Boston, or something odd like that. Boston EMS, they have to have their special thing, but can't teach an old dog new tricks, and you want to see if they can say it's slurring or they're unable to speak. One of the things with facial droop, Karen, you mentioned Bell's palsy, and often when you see Bell's palsy, that's when you have a peripheral nerve, your facial nerve is paralyzed, and it's pretty pronounced. People have a big facial droop. What you should have, if you have a stroke, is you'll have facial droop down here, but you'll have forehead sparing. They'll still be able to furrow their brow and raise their forehead because you have forehead sparing the way the nervous system works. Bell's palsy, they can't do that. They have droop up here too. So it's kind of fun. People come in as stroke alerts, and I feel like a magician. I look at them and I have them do that. I'm like, you have Bell's palsy, and just go on to the next patient, and we cancel everything. So it's a cool thing for you guys to look at. And if they have a pronounced, they can't furrow their brow, it's probably a Bell's palsy. Arm drift again, about 10 seconds. You want 10 seconds. You want to hold up. Can they not move it at all, or is it slowly drifting away on one side? The benefits of this is quick and easy to remember. It is good inter-rater reliability. I think physicians, EMS providers do a good job at this. It's fairly sensitive at 66%, and it's specific. 87% of these patients actually have a stroke, and allows earlier identification of a treatable stroke. So let's do the FAST-ED. I have a couple more videos. They're a little long, but I think they're involved, but it's good to see just to kind of reinforce it.
FAST-ED is a double acronym, which stands for Field Assessment Stroke Triage for Emergency Destination, as well as face, arms, speech, time, eye deviation, and denial of laugh. The double acronym conveys the original intent of the scale, as well as summarizes all of the assessment steps associated with completing the scale. Anytime a patient presents with an acute onset neurological complaint, assure the patient is screened for stroke. How stroke signs and symptoms include hemiparesis, which is weakness on one side of the body, hemiplegia, which is paralysis on one side of the body, facial palsy, also known as facial droop, dysarthria or slurred speech, which is a vocal motor deficit making it difficult to articulate speech, dizziness and vertigo, expressive aphasia, which is the loss of the ability to produce written or spoken language, receptive aphasia, which is the loss of the ability to understand written or spoken language, eye deviation, which results in a fixed gaze or difficulty looking to one side, denial neglect, which is the inability to respond to stimulus on one side of the body, usually the left side. Stroke signs and symptoms can be less obvious and also an altered level of consciousness, sudden severe headache with no known cause, visual disturbances, generalized weakness, motor ataxia, as well as frequent or unexplained falls. If any potential sign or symptom of stroke is identified during the initial patient's assessment, screen for stroke by applying the first 3 steps of FAST-PD. These steps comprise the stroke screening portion of FAST-PD. First, assess the face for partial or complete paralysis to one side. Then, assess the patient's arms for drift or an inability to lift one or both arms. And assess for speech changes, including dysarthria or slurred speech. Expressive aphasia, which includes testing for the patient's ability to name at least 2 of 3 objects that are easy to identify. And receptive aphasia, which includes testing for the patient's ability to follow a simple command. If these steps sound familiar, they should. They're the steps of the Cincinnati Prehospital Stroke Scale, with a few additional criteria added to the speech assessment. To make the scale easier to learn, FAST-PD was intentionally designed to be analogous to the CPSS, which has been used by most EMS providers for almost 2 decades. If signs and symptoms of stroke are not detected during the stroke screening phase of FAST-PD, EMS providers should consider ending the stroke assessment and continuing to assess and treat the patient based on their condition for local protocols. If signs and symptoms of stroke are detected during the stroke screening phase of FAST-PD, the deficits should be assigned points based on the scoring criteria defined in the scale. In just a moment, I will discuss in detail the scoring criteria of FAST-PD. But first, let's continue with our overview of FAST-PD by briefly discussing the next step, time. When signs and symptoms of a stroke are noted, EMS providers should make a reasonable effort to obtain and document 2 different sets of times. A last known well date and time, which is the date and time the patient was last known to be at their normal baseline, as well as the date and time of sign and symptom discovery, which is the date and time signs and symptoms of the stroke were first discovered. For example, a patient went to bed without stroke signs or symptoms at 10 p.m. the night before. The next morning, family identified stroke signs and symptoms at 6 a.m. when the patient awoke. In this case, their last known well date and time is 10 p.m. the night before, and the stroke sign and symptom discovery date and time is 6 a.m. on the morning the patient woke up. Assure you document both sets of dates and times. Finally, when signs and symptoms of the stroke are detected, the remaining steps of FAST-PD should be completed. These final steps consist of testing for eye deviation to identify a fixed gaze or difficulty looking to one side, and when indicated, testing for denial neglect, which includes anosognosia, or commonly known as denial, is the inability to recognize weakness in their weak arm, and asomatoagnosia, or commonly referred to as neglect, is the inability to recognize or identify with their weak arm. Again, when signs and symptoms of a stroke are noted during the screening phase of FAST-PD, score the severity of the deficits noted. Then, complete and score the remaining steps of FAST-PD. The assessment and scoring criteria for each step of FAST-PD consists of the following. For facial palsy, ask the patient to smile or show their teeth. Evaluate for facial asymmetry and/or a flattening of the nasolabial folds. The nasolabial folds are the folds that run from both sides of the nose to the corners of the mouth. A score of 0 indicates no facial droop or only minor paralysis to one side of the face. To Conversely, the score of 1 indicates partial or complete paralysis of one side of the face. For arm weakness, ask the patient to hold both their arms out in front of them, palms up, with their eyes closed for a count of 10. A score of 0 indicates no drift, or both arms slowly move down equally.
Ma'am, I'm going to have you lift both arms up, palms up, hold your eyes, now keep them there for a count of 10. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10.
A score of 1 indicates arm drift, or some effort to lift the affected arm against gravity.
Ma'am, I'm going to have you lift both arms up, palms up, close your eyes, now keep them there for a count of 10. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10.
A score of 2 indicates no effort against gravity or no movement in one or both arms.
Ma'am, I need you to lift both arms up, palms up, for a count of 10 and close your eyes. 1, 2, can you lift your left arm for me? I need you to lift this up. 3, 4, 5, 6, 7. Can you move your left arm up? 8, 9, 10.
When assessing speech, check for dysarthria. Consider asking the patient to repeat a simple phrase. For instance, ask the patient to repeat, "You can't teach an old dog new tricks." The patient should be able to repeat the phrase without slurring. Dysarthria is a positive sign of stroke that is not awarded points on the FAST-ED scale. More on that in a moment. Next, as a part of the speech assessment, check for expressive aphasia by asking the patient to name 3 common, easily identifiable objects. For example, their phone, a pencil, and a remote control. A score of 0 indicates the patient was able to name all or at least 2 of the 3 objects. A score of 1 indicates the patient could name none or only one of the 3 items correctly, or is unable to speak at all. Next, check for receptive aphasia by asking the patient to perform a simple task. For example, ask the patient to show you 2 fingers on their unaffected arm. It's important to avoid demonstrating the task, as the test is intended to assess the patient's ability to follow verbal instructions. A score of 0 indicates the patient was able to show you 2 fingers when prompted.
Can you show me 2 fingers on your right hand?
A score of 1 indicates the patient was unable to perform the task.
Ma'am, can you show me 2 fingers on your right hand?
Aphasia is one of 3 cortical signs tested during the FAST-ED assessment. Cortical signs of stroke signal the involvement of the cerebral cortex, which is the seat of higher order function in the brain. Cortical signs are strong indicators of LVO stroke. FAST-ED's effectiveness at detecting LVO stroke is due in large part to the scale scoring matrix, which gives higher scores to cortical signs. Remember, when signs and symptoms of stroke are detected, make a reasonable effort to obtain and document the patient's last known well date and time, as well as the date and time of stroke sign and symptom discovery. The next step is assessing for and scoring eye deviation. To do this, ask the patient to follow your finger with their eyes, without moving their head, as you move your finger horizontally from side to side in both directions. A score of 0 indicates the patient is able to look to both sides without difficulty. A score of 1 indicates the patient is able to move their eyes horizontally in both directions, but not without clear some cases, the patient may not be able to move their eyes past the midline of their body. A score of 2 indicates the patient's gaze is fixed to one side and does not move. Eye deviation is another cortical sign and a strong indicator of LVO stroke. When eye deviation is due to stroke, the eyes will be deviated or looking towards the side of the stroke. If aphasia was absent, and only if it is absent, check for signs of denial and neglect. Check for denial by showing the patient their weak arm and ask them, can you feel weakness in this arm? A score of 0 indicates yes, the patient recognizes the weakness in their weak arm.
Do you feel weakness in this arm? Yes.
A score of 1 indicates no, the patient was unable to recognize the weakness in their weak arm.
Ma'am, do you feel weakness in this arm? No.
Finally, check for neglect by showing the patient their weak arm and ask them, whose arm is this? A score of 0 indicates yes, the patient recognizes or identifies the weak arm. A score of 1 indicates no, the patient does not identify their weak arm. Denial and neglect are also cortical signs and another strong indicator of LVO stroke. But again, denial and neglect are only tested when signs and symptoms of aphasia are absent. If any signs and symptoms of aphasia are present, skip the assessment for denial and neglect. Once the assessment steps of FAST-TD are complete, calculate the final score. A FAST-TD score of 4 or greater indicates a high probability of LVO stroke. Again, the use of a FAST-TD scoring checklist, like the one on your screen now, may be helpful to conduct the assessment as well as calculate the total FAST-TD score. It is important to understand that a FAST-TD score of 0 does not mean the patient is not having a stroke. There are signs and symptoms of stroke not scored by FAST-TD due to their typical lack of association with LVOs. For instance, dysarthria is a sign of stroke that is not awarded points by FAST-TD. In addition,
All right. So there's an app for that, which makes it way, way, way easier. I use this in the ED. It'll actually walk you through all these steps. It's free. Join Triage, the name of it. You can use it offline. You don't have to be connected to the internet when you're using it as mapping stuff, and it'll take you to the closest stroke center, but it doesn't really matter for us because we know where we're going to go. But it's super helpful. So I encourage you guys, and I can send this out by email too, to download that app for sure, because it's going to be a big help. I'm going to show you one more video that goes through the FAST-TD again. It's a little quicker video, not as, I think it's more exciting. It's really not that more exciting. But it kind of goes through it using the app as well. So.
we recommend to download the FAST-TD app from the App Store prior to initiating this training. The FAST-TD assessment requires a combination of a few questions and a brief physical examination. Our goal is to train first responders to assess acute stroke patients in the field with the FAST-TD scale and determine the level of care needed in each situation. After the assessment of the stroke severity, the closest and most appropriate level of care, a primary or comprehensive stroke center can be activated to continue the acute stroke mode. After opening the FAST-TD app, press Start to initiate the triage. The initial questions involve anticoagulation, the patient's age, and the time the patient was last seen well. The physical exam starts by observing and subsequently asking the patient to smile. Watch for any asymmetry of the mouth at rest and during smiling.
I think this guy's a better actor. I'm just going to go out and say it.
It is helpful for the operator to verbally count down from 10. Observe for any downward arm drift prior to the end of the 10 seconds and score your findings in the FAST-TD app. patient to name 3 familiar objects. Slurred speech does not score any points in this category. Store your findings in a fast ED app. Ask the patient to show you 2 fingers. Observe and score in the app if the patient understands and follows the commands. The patient is asked to follow your finger as you move across the patient's line of sight. Sometimes it is useful to ask the patient to follow your face. In a gaze preference, the patient is able to follow the finger but with difficulty. In forced deviation, the patient's eyes are deviated to one side and do not move to the other side. There are 2 extra questions regarding the patient's self-recognition of any degree of weakness and the recognition of the patient's own left arm. After the exam, the app will automatically calculate the FAST ED score and recommend a level of care based on the severity of acute stroke.
All right. So that app is super helpful because when I first started looking at this stuff, I said it seems kind of overwhelming at first when you start looking at all the steps, but the app really walks you through it. And I think it's very helpful. All right. So just to review what we do for these people. So you want to check your blood glucose, right? Help identify that mimic. If you're putting in an IV or we'd like an IV, where the right AC is actually preferred, and that has to do with if they go for mechanical thrombectomy, they'll typically go through the left side. It's sort of the opposite of STEMI, actually, which is a little weird, but right AC preferred if you can do that. Obviously, that pre-notification stroke alert, time last known less than 3 hours at a positive Cincinnati. Those are our TPA eligible patients, and last known well greater than 3 but less than 24 with a fast ED of greater than 4. Those are our large vessel occlusion patients. We might be able to do mechanical thrombectomy. It might be helpful also because this is more of a Cheshire thing, but I think it's probably helpful if you can call the MedCon phone and get patient demographics. Do you guys find that helpful here, Todd? It seems a little less important here, but they're super. We actually like preload them on the EMR and get like everything started. So, yeah, yeah.
I mean, one of the most helpful things that I've found in the recent past, but I never think about myself, in the truck, 5 RSIs.
Yeah. And Grace Cottage, probably I'm the same boat, I'm sure. So.
Well, they still accept initials and date of birth, so they will like register patients.
Okay. EMS management, obviously ABCs, oxygen. Remember, it's just like anything else as required. We want to keep the SATs between, in general, 94 to 99%. We don't need to blast on oxygen. We don't manage blood pressure because we actually, certain types of strokes, we want to keep that blood pressure a little high because that'll help perfuse the brain. We don't give aspirin for strokes pre-hospitally because we want to make sure they're not bleeding first. Cardiac monitor, yeah, if you can, 12 leads nice, just helps us identify if they have atrial fibrillation or cardiac arrhythmia that's contributing to this, but it's a little lower on the list, I think. If possible, right AC for an IV, definitely a finger stick glucose. Neuro assessment, yes. Last known well, absolutely. Early hospital notification, rapid transport's important. So this is what the new protocol is going to look like. You guys will see this in a couple months. Basically, we're looking for stroke symptoms. We talk about all the stroke symptoms here, including visual disturbance and stuff that's not on any of the scales we use, but be like, yeah, this patient's having vision changes. They're got blurred vision, double vision, et cetera. Hey, Shiver. That's also important to know that they might not be a stroke alert, but you could still do an assessment and say, I'm worried about a stroke, because sometimes we don't realize that some of these things these chameleons are pretty hard to pick up. Routine care, screening tool, if that Cincinnati stroke is positive, go to your fast ED. Again, all the stuff we talked about. A little bit of oxygen if you need it, head of the bed if you need it, minimize on-scene time, transmit EKG if available, correct the glucose for greater than 60. rapid transport, and that IV right AC preferred. They like, the neurologists like a little bit of a 250 ml bolus. I suspect the evidence isn't fantastic. I think it has to do with they're going to may get a little contrast flow with their kidneys. It might help the what they call the ischemic per number and help with perfusion. I suspect it's witchcraft, but it just seems to be standard practice. They like it, and 250 ml is going to hurt anybody. So this is your general stroke screen. That's pretty much in the protocols now. Here's Cincinnati. Then you move on to your fast ED. I would say use the app. And this is the stroke criteria again. Blood glucose has been corrected. There's not another identifiable cause. Stroke screen, they go to 4.5 here. We generally use 3 at the hospitals locally. FDA has approved thrombolytics out to 3 hours. Some people give it up to 4.5, so it's a little neurology dependent, but we generally use 3. And this fast ED greater than or equal to 4, and time lasting well is less than 24 hours. This is just some destination guidance they put in the protocol. It doesn't really affect us because we don't have anywhere that can do mechanical thrombectomy close to us. So they're just saying here, basically, if you have an LVO greater than 4.5, less than 24, go to an endovascular center. The only real place right now is Dartmouth. I'm guessing Bay State, but I should probably find that out. I think Bay State probably does 24-hour mechanical thrombectomy. Dartmouth does. UVM is a little bit hit or miss right now. They had at one point, we're doing 24-hour coverage. I think they lost one of their stroke neurologists. So probably Dartmouth or Bay State would be our closest. And if they're going to be mechanical thrombectomy, we'll evaluate them here. We'll fly them. And the testing we do here is a little different to determine if they're eligible or not. And you could do your thrombolytic checklists if you want. And then there's just some pearls and lists of anticoagulants here. So many more of these novel anticoagulant blood thinners are coming on the market. So what do we do at our hospitals when we arrive? And what we're doing here is, at least at Chester, we're pre-registering. Maybe it sounds like Grace Cottage there as well. We should be doing a brief assessment in the ambulance entrance. Sort of I do a quick meet and greet. Hey, Mark, what's going on? Assess the patient, make sure there's no airway issues, go right to CAT scan. So I can kind of do my quick patient contact. They'll usually go direct to CT by EMS unless there's something else. Somebody's in the scanner's not available, or there's some other management thing. I look at the patient and say, this person's got a bad airway or something else has to be done. If there's no suspected large vessel occlusion, so their fast ED is low, but they're less than 3 hours, they go to CAT scan without contrast. And that's just the reason we do that is we want that CAT scan to be normal. If that CAT scan is normal, it tells me the stroke is early versus, ooh, there's edema starting and it looks like there's ischemia. That person's probably not going to get TPA because I'm at risk of causing a bleed. So we're looking for a normal CT and to make sure there's no bleeding or a mass or something else that would be a contraindication to giving TPA. If we think there's a large vessel occlusion, they have that fast CD of greater than or equal to 4. They get the same CAT scan without contrast. If that looks good, then we do another CAT scan called CT angiography where we do it with contrast to see if there's a blockage in one of those large vessels. That's sort of the approach we're taking. In general, the ED provider is probably going to come down to CAT scan with you. The reason is, Dartmouth, they have like a bunch of availability of neurologists and people going to the scanner with them. It's not nice for our ED techs to say, or our CT techs who are great, to say, you decide if the patient can get contrast and everything looks normal on that CAT scan. We need a provider looking over their shoulder. Although often we say to CT scan, you see anything on there, and we're using their advice as well, but it's just out of their scope and it's not fair to them to make that decision. And that would be what we'd see, basically that blockage right there. So just get that cut off. In the ER, we do some labs, electrolytes, regular blood work, EKG, chest x-ray, bedside assessment. We're always thinking of the stroke mimics and chameleons we talked about. We're getting neurology involved right away. And we do something called an NIHSS score. Greater than or equal to 6 indicates a large vessel occlusion. This fast ED stuff is part of that NIHSS. We don't think it's fair for EMS providers to do that whole thing because it's pretty involved. How long does it take to do that? About 10 minutes? Yeah. And it's involved. I mean, and then we want to know if they're TPA or thrombectomy eligible. So this is the problem with thrombolytics. They're good, but we know that for every 100 patients I treat with TPA, 32 benefit, but I kill 3 people or I harm 3 people with bleeding in the brain. So it makes a lot of us nervous. And some of the data people argue about some of the data on lytics. I think there are subsets of patients that lytics really help if you give them early for stroke. But you'll see neurologists kind of give them to a lot of people. And the joke in the ER is I give you thrombolytics. Somebody has their big stroke or they have a stroke. I give them thrombolytics and they get better. And so it might be a TIA. Like sometimes it may just be a TIA that got better, but it's a little controversial because you can harm people with it. So if TPA is not given, we'll give some aspirin. We give some Plavix. We try to manage our blood pressure at that point. If there's nothing abnormal in that CAT scan, we try to keep that systolic less than 180, diastolic. If it's high, if we try less than 180, diastolic less than 105, we get some Labetal and the cardipine, some either beta blocker or calcium channel blocker to bring that blood pressure down if it's high. And if they're thrombectomy eligible, they have a large vessel occlusion in their CTA. We try to get them the hell out of there and get them to a center that can do that mechanical thrombectomy. They go up to a center like Dartmouth and maybe Bay State, get their mechanical thrombectomy. That's a picture of the clot right there, type of stuff they'll pull out. And these are our goals in the ED. We want to get them evaluated within this. A lot of this is stuff we're doing already. We want to evaluate them in 10 minutes, get a CT brain, 25 minutes, get that result back within 45, lab results 45 minutes, TPA within 60. It sounds like a lot of time, but boy, that's a lot of stuff to do, including getting a CT read. And then thrombectomy as soon as possible if they're eligible. So in summary, you want to know their time. Last known well is really, really, really important for us. It's going to help us. Don't worry. Try to get those family members to come with you or that witness to come with you. Contact information is important if they're not coming with you. You want that pre-hospital stroke assessment, Cincinnati, and a fast ED. Don't forget your blood glucose. Don't forget your IV access. Pre-hospital notifications, super important. Remember, less than 3 hours at a pod in Cincinnati or greater than 3. If they're greater than 3 hours and less than 24s and they have a capacity greater than 4, that's stroke. Questions? A lot of information, but use the app. And I'm also going to make this available. I don't know, did you record it as well, Jeff? Okay, so we have a recorded here, and I have another version I can put out. I can send you guys a YouTube link as well. So. That one you can, yeah, it won't give you the mapping stuff if you don't have self-service, but you can run the app. And when you go into it, I've never registered for it. It's like register, and I put I'm a guest, and it brings you right in. So I have used it without self-service. Yeah. And I use it, I mean, I would imagine like the nurses will use that app as well. I mean, it's super easy to use. Just bring it up and go through the questions. So. Oh, we should play with it. I'm told it works without it, but okay. Oh. Yeah, it used to be Fast CD, and they changed the app a little bit, so it might be that they updated it. So, other questions? All right, thank you for your patience. And I also know a lot of the EMS folks have been, I think the medics been doing an NCCP refresher. There's been a refresher going on as well. So there's been a lot of stuff going on over the last week. So I appreciate a lot of people being here because it's busy. Yes, Todd. Like a nurse on a transfer? I mean, I think you're going to initiate it in the hospital. But I think that, I guess the short answer is, yeah, I wouldn't delay. If you're going to get it anyway, and I know you're going to be a mechanical thrombectomy patient, I mean, how long do you wait? I don't know. Yeah. But what's interesting about that, so the worry with TPA is like we used to not, if we gave TPA, we transferred all patients at Cheshire to Dartmouth. And the reason they transferred, they said, if they bleed, I can't do anything for them. But what we've learned from talking to neurology and neurosurgery is they say, yeah, if they bleed, we can't do anything for them either. So there's not a lot they can do, unfortunately. It's an intracranial hemorrhage and they have to treat it, but you're right. I mean, sometimes people have bad outcomes, but they may have that bleed, several hours later, or they may have it within a couple hours. So you just don't know. So I wouldn't delay transfer personally, but. Other questions? Delayed like he would initiate the TPA and transfer the patient, go like have him in the ambulance as go up to somebody. You're probably going to start it here anyway. I mean, I guess the short answer is yes, but it'd be a weird situation that you'd be that fast, especially trying to get acceptance of a doctor and all this stuff. You'll be. Yeah. Yep. Do you guys know about ED? So the hospital has this. Basically, there's ER in a box up on the wall that comes Dartmouth during the day, Monday through Friday, and it's Avera out in the Dakotas at night cover. And 99% of the time we use it for nursing support, but you can also get a physician on there that's there. And it's pretty awesome because it's another set of eyes looking over you, another set of hands to document. And they will arrange transfers for you and kind of do that legwork. So I think it's going to help a lot in the ED.
For us, we only have one provider in the ER, so like the other night I had to give a guy blood emergency.
Yeah.
I had the provider that was available on the screen talk to the patient about
Yeah.
verbal progression to get blood, where I didn't have the provider to get.
I think you're going to find it valuable here. It's good. So, all right, other questions?
Jim, you're saying that probably middle end of March we'll be rolling this out officially?
I'm guessing it's going to be part of. We can use it now. I mean, we can start using this protocol locally. It's nothing that I think we need the state. They know we're doing this down here, but it'll officially rolled out again. You'll see this again with the protocol rollout. They're guessing March is what they said. January. I haven't heard an update. And it's usually state time. I usually add 2 to 4 months. That's sort of so. Yeah. But I think the protocol's awesome, and they did a great job. Thank you to Mark. Mark was very involved on the committee and stuff, and I think you guys did a great job for helping out. So, all right, please drive safely, and I hope everyone had a great evening. There's also next Tuesday, Monday. No, hopefully on Monday. I'm working Monday. Next Tuesday, there's M&M rounds at Grace Cottage. We'll be reviewing some cases too. So, 4 o'clock. So, all right. Thank you guys. Have a great night. I appreciate your time.